Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy.
This episode of Unscripted, the AMCP podcast, is sponsored by AbbVie. AbbVie, they find answers that make life better for patients in our world. Rare diseases, even more rare blood cancers, don't get much airtime. But when a new FDA approval emerges for an ultra-rare, aggressive hematologic malignancy, it's really worth paying attention. Pivekimab Sunirine, or PVEK, just got the green light for adults with blastic plasmacytoid dendritic cell neoplasm, or what we'll refer to as BPDCN for short. So what does this mean for managed care? Well, I'm glad you asked. I'm Dr. Ryan Humschild. I'm Vice President of Pharmacy at Emory, your guest host, and joining me today is Dr. Pemaraju. Dr. Pemaraju, could you give your introduction?
Well, thanks, Ryan and team, for having me. I'm Naveen Pemaraju, Professor of Leukemia at MD Anderson, UTMD Anderson in Houston, Texas. I am the inaugural founding director for our BPDCN program and also the co-section head for myeloproliferative neoplasms. So my focus is on improving the lives of patients with rare blood cancers. Thank you, Ryan, for having me.
Yeah, thanks for being on. Someone with your expertise, I think, is really awesome to talk through this subject. And so maybe for the listeners who may not be routinely managing something like BPDCN, can you start by describing the disease and what makes it so uniquely challenging as a hematologic malignancy?
Yeah, thanks, Ryan. It's important to start because even among academic hematologists, this is still a quite rare and elusive entity. So I would say three major items to orient our listeners to understand what this BPDCN is. So number one, the name. What an unwieldy, difficult name. It's actually changed half a dozen times over the past 25 years. So blastic, or B, means immature cells. Those are not quite yet mature. Plasmacytoid dendritic cell, PDC, the middle kind of confusing letters, that's the type of bone marrow blood cell that likes to go to the skin, blood, bone marrow, even the CNS disease and lymph nodes, and the neoplasm, new growth, or cancer. This is a rare disease. We think possibly, Ryan, only about 500 to 1,000 Americans a year diagnosed. Number two, I would say, is that it's a CD123 or IL-3 receptor alpha expressing leukemia cancer with skin predisposition and involvement. And then number three, which leads into the fourth point, number three is that it's rare among our blood cancers, our leukemias, because it loves to go to the skin. So that's one of the defining features that you'll hear over and over. Not necessarily 100% of patients, but the vast majority will have skin involvement either at baseline or later on. After the skin, blood and bone marrow, as you'd expect in a traditional leukemia, lymph nodes, interestingly, like a lymphoma. And then number four, unfortunately, a high predisposition for central nervous system involvement. So what people should hear about the stage setting for BPDCN is that it's a rare CD123 expressing leukemia that loves to go to the skin, but also to the lymph nodes, the circulating blood, CNS. It historically had a low overall survival. Unfortunately, patients had less than 1 year overall survival as an average. And then with the advent of the agents we'll talk about here, targeting CD123, we believe we've at least doubled and possibly even more that overall survival in combination with other agents, clinical trials, and stem cell transplant, right?
Well, I think that gives a great context. And I mean, honestly, you think about it, if I'm going to want to be treated, I need to go to a subspecialist like you, right? Who's understanding kind of the treatment, the evolution of disease, even the name, as you mentioned. And maybe if you could further characterize a little bit, what does historically the treatment journey look like for a newly diagnosed patient? What are those limitations? And what does it mean for patients living with this ultra rare aggressive malignancy to have another approved FDA treatment option to improve their lives?
Yeah, well said by you. If I had to use one word that my patients describe most commonly, is that it's scary. It's fearful, isolating, and lonely, Ryan, when a patient is diagnosed with a leukemia in general. But when you're diagnosed with such a long, unwieldy name that one cannot pronounce, one's doctor cannot pronounce, one's doctor's never heard of, it adds to that fear. So I think that's the defining feature of the ultra-rare blood cancer. Historically, the tissue of origin wasn't understood. The disease was thought to be mixed up with other more common leukemias. And so as you might imagine, the treatments were borrowed from other more common leukemias. The addition of the CD123 drugs, so now two to present that balanced attack, which is the first drug was tagraxofusp or TAG. And then now, very exciting, the second drug, the CD123 drug you mentioned, pivekimab sunirine, or we'll call it PVEK, has a different side effect profile. Both are highly effective in treating the BPDCN, either frontline or relapse refractory. And both very nicely were able to be coupled with an allogeneic stem cell transplant for a combined curative approach. So I would say the treatment journey went from non-specific borrowed multi-agent chemo regimens remarkably, right, in the span of about 20 years to now a monotherapy that targets the exact potentially driver or marker of the disease that causes high rates of remission, and then when coupled with stem cell transplant may offer for the first time a potential cure for these patients, right?
Wow, I hear the word cure. I hear kind of that armamentarium getting built now. And like you said, a therapeutic area where really regimens were being borrowed. And so it looks like not only are you providing, improving lives, but you're also providing hope. And I think that's really key. And, one of the things you really talked about was the trial design and the way that we're looking at both these treatment naive and relapse refractory BPDCN patients. So if you can, I'd like to unpack a little bit of the Cadenza trial because I
Oh,
feel like
great.
that's really key, right, into driving this, and really, it was a multi-center open label, single arm study. And so if we could talk about that a little more, tell me about PVAC as a CD123 directed antibody, and what did this trial really unpack for you in terms of, what was the treatment naive, what was the relapse refractory, and how did that impact the overall efficacy and outcomes?
Oh, excellent. I'd be honored to. So I was honored to lead this so-called Cadenza study, which was the pivekimab sunirine or PVEK for patients with BPDCN. And importantly, as you mentioned, we involved both frontline and relapsed refractory patients. A unique, fascinating molecule, the PVEK. So essentially what I want people to think of is it's an antibody drug conjugate, an ADC that we call it. It's got a couple different parts to it, but picture an antibody of a CD123 binding arm. We have this unique cytotoxic payload. We'll abbreviate it to IgN. And basically what you're doing is this sort of Trojan horse approach where the ADC homes into its receptor target, CD123 or IL-3 receptor alpha, on the surface of these BPDCN cells, and it binds to it. So that's the ADC binding, antibody drug conjugate. But then it gets internalized into the cell, and it releases its payload, causing cytotoxic damage, cell death to these BPDCN cells, and then leads to this removal of those cells into the circulation, so cell death. So that's the PVEK molecule, very interesting CD123 ADC. It's the first of its kind, second only CD123 targeted drug approved. The trial is fascinating, Ryan. So the Cadenza, as you mentioned, it's an ultra-rare disease, so not randomized. It was an open-label, single-arm, multi-center study, phase 1/2, we called it, of the PVEK monotherapy in patients with this high risk, high rate of chance of dying from this disease. All patients had CD123. So two groups. One was a frontline group. They did not have prior systemic exposure. The second was a relapse refractory group. Importantly, Ryan, in the frontline group, BPDCN, although it's rare, can commonly associate with a second cancer, believe it or not. We call that PCHM, prior or concomitant hematologic malignancy. So I'll talk about those two separate groups in the frontline setting. Importantly, the PVEK drug is very easy to give. It can be given actually as an outpatient or inpatient, but amazingly outpatient. IV, quick infusion, 30 minutes or less, day one, every 3 weeks. So you can say day one of a 21-day cycle. And the recommended phase 2 dose was a small dose, which is 0.045 mg per kg. The results, Ryan, look very fascinating, very encouraging. So PVEK in the frontline setting, so I'll quote to you the 33 patients, all of them, was a remarkable 85% rate. That's called overall response rate, 70% of whom were complete remissions. And that held true even in the 20 patients who were the de novo, not without the PCHM, 80% overall response rate, 75% CR rate. Overall survival was actually quite nice. So this is a deadly disease. In the frontline patients, whether you had a PCHM or de novo, so that's 33 total patients, the median overall survival was 16.6 months. But there was a nice tail to the curve, and those patients were essentially people who were able to go to allo transplant in CR1. And the median follow-up was about 21.5 months. When you look at those patients who went to transplant, we do have responders now who are out and going several years out if they were able to go to transplant. And that was quite a few of these patients 13 out of the 33 patients were able to go to transplant. I showed you that they were older age. Finally, Ryan, I would say any new drug, you have to talk about new side effects in the same breath. It was a well-tolerated agent. There was some myelosuppression, so that's anemia, neutropenia, thrombocytopenia. You expect that in these CD123 targeted agents. Non-hematologic, I would point out to people maybe three things. Peripheral edema was common, probably 3/4 of the patients. So that's swelling or fluid retention in the extremities, for example. There were about a quarter of the patients who had infusion-related reactions, and there was a small but significant portion of patients who have liver function abnormalities, even having to watch for what's called VOD SOS, and that's appropriately a black box warning on the drug. So let me pause there. It's quite a bit of data. I wanted to put it out there as the cadenza study, frontline relapse refractory, that directly led to the FDA approval. Ryan?
Yeah, I mean, you nailed exactly what I was looking for. What a great way to break down a study in a rare disease that people can understand it, right? And I love how you led in with the innovation and technology of an antibody drug conjugate, and that cytotoxic payload, the way it targets, right, the CD123, I think is important. And I think to your point, bridging to transplant, that's a key outcome that we're looking for in these populations. So maybe if you could, my question is, we have clinicians, right? And they're thinking about PVEK, they see the data out there. How should they think about it relative to the existing BPDCN treatment approaches in terms of tagracifosp and intensive chemotherapy-based strategies? Is this something that you look for in the relapse refractory? Does this bring innovation in the front line? How should they start including this when they're thinking about kind of that total treatment portfolio?
What a great question. It's exactly where the field is. So I'll give kind of the standard approach, but it's evolving in front of our eyes in a good way. I think three key tenets from your beautiful question. Number one, I would say for the fit patient who's eligible and can go, stem cell transplant is still the major part of the curative journey in BPDCN, particularly if offered and given in the first remission. So I have to say that out loud. A lot of people in my field definitely know that, but let's get that word out there. So no matter what, stem cell transplant, if you can go to it. Now, number two, the vast majority of patients, or a lot of the patients, can't always go to transplant for a number of different reasons, both medical and health and logistics, et cetera, et cetera. So you really have to divide out patients into young, fit / stem cell transplant eligible, non-transplant eligible. That's part one. Part two is, as you said, for the first time ever, we have a choice of therapies. There's not going to be randomized data. So you said it correctly. If you look in NCCN guidelines, my own papers, position papers, expert, it's what you said. There are choices now. Allo transplant, if you can, if the patient can, and CR1, a variety of different chemos and targeted therapies that run the gamut from single agent targeted therapy all the way to multi-agent cytotoxic chemotherapy, along with the venetoclax, and then a CNS prophylaxis. For the next part, I would say of what you asked is clinical trials are always recommended as well for frontline or relapse refractory. It's a rare disease. Lastly, I would also say what's interesting is auto transplant, Ryan. That's been used in several select cases, including me and my team. And so you said it nicely in the beginning, multidisciplinary team effort, I think, for BPDCN. If we can refer these patients to a larger academic center. Great. You said that at the top. Two, I see it as a multidisciplinary disease, unlike some of the other blood cancers, which can be contained within one team. So it is multidisciplinary. Leukemia, stem cell transplant, pediatrics for the AYA younger patients, derm pathology, so skin pathology, heme pathology, if you have it, blood and bone marrow pathology, and then the pathology team in general, and then dermatologists, skin doctors. Some of these patients will come in, particularly the younger patients, straight from the derm clinic to us, not the other way around. So if you have a skin lesion that's abnormal, persistent, recurrent, tissue is the issue, Ryan. Make sure we're getting a biopsy, maybe even serial biopsies over time. Sometimes patients may get antibiotics or steroids. It may go away. Here's a purple lesion that's not going away. So maybe a good plug for skin awareness, UV light exposure. And then the final comment I would say is that we've traditionally had taught that BPDCN was a disease of older males. In fact, that's what you'll see in the majority of our studies, our papers. Actually, I just want to put out there that as there's more awareness, programs like this one, pathology awareness, dermatology awareness, leukemia team awareness, we're having more and more diagnoses in younger folks, so babies, infants, teenagers, adolescent, young adults, women, younger patients, as I mentioned, and also not even skin involving. So they come in as a leukemic presentation, so bone marrow, blood, or lymph node involvement, lymphoma presentation. So how about that? BPDCN, a skin predominant leukemia that may not have skin lesions, and then make sure we're checking for central nervous system involvement. So that I hope captures the excitement of the options, and we're trying to decide them in real time, Ryan.
I mean, you really gave a good breakdown. I mean, the options, even the way the patients are presenting. I won't forget the tissue's the issue. I'll give you credit for that
There you
tagline,
go.
by the way, because I think that is,
I didn't come up with it. Someone came up with it, but
hey,
it's ours now.
I'm giving you the credit because I think what it does is creates that good awareness, right? And it's a team sport, as you mentioned. You might be that quarterback to BPDCN, but there's so many people that you're working with to coordinate care, and that multidisciplinary is key. And, when I think about that, this is the presentation, right? Like you said, it's more of a rare disease. There might be people that do emerge in community oncology. And so we got to make sure that they know the referral pathways. One of the things that stands out to me is something you highlighted early. It can be given in the outpatient phase of care, right? So cycle 1, day 1 of a 3-week or 21-day cycle. And for patients now, there used to be this complex inpatient management, and not saying that can't be part of someone's journey, but now having a therapy that can be given in the outpatient phase of care. I think about a state like Texas, right? Yes, there's, US oncology and Texas oncology, but academic subspecialists, there's times patients have to drive to come see you. And so having an outpatient therapy as opposed to something that's done inpatient only does provide a little bit more freedom to a patient, accessibility. How do you see that evolving in the patient journey as well?
Yeah, absolutely right. And I love the way you characterize the patient journey. It's for me, for you, for us, it's all about the patients. I really love it. It reminds me of two things to answer your nice question. So one is the importance of the multidisciplinary team. Now, we shouted out earlier all the healthcare providers, but I do want to give a special shout out to the PharmDs, nursing care, advanced practice providers, social work, case manager, all the other allied health professions, because especially as I think about both the inpatient, outpatient, these complex rare blood disorders require a village, a team effort. And so it is important. And particularly with the days of tag monitoring, coordination with the PharmDs in nursing, weekend, holiday, night dosing, albumin monitoring replacement. I agree with your premise. I think the second drug approved, the PVEK now, also targeting CD123, is a fascinating option. As you say, it's meant to be given potentially as an outpatient, even from the beginning. Now, that's every patient and doctor situation has to be evaluated locally by the physician. Some of these patients may need to be admitted for induction, other reasons, et cetera. But it is nice to have an outpatient option, one that's less frequent dosing. So rather than 3, 4, 5 days every month, one dose, a lower dose at that, very potent drug. And the side effect profile might be more convenient for many patients. The lack of major findings of capillary leak syndrome, you always have to be on the lookout for it in any CD123 drug. But majority, it's peripheral edema. Usually we're seeing it around cycles 3, 4, 5, for example, something that can be managed as an outpatient and needs to be watched over closely. The liver tests are something that can be watched closely as an outpatient. And particularly, a lot of our patients are older, 70s, 80s, 90s, but it does indicate that there's a potential for less touches to the healthcare system. So I like this characterization. The different side effect profile may favor one patient over the other. And then I have to say also that you have to watch out for all these targeted agents in the spacing of stem cell transplant. Obviously, with the PVEK, make sure you're watching out for the VOD, a well-known complication of transplant. And then with the tag, the capillary leak syndrome, for example. I think that you're able to get older patients a treatment that has a high rate of CR, so complete remissions, on top of that overall response rates, on top of that a very high rate to go to stem cell transplant in an older population that's 69, 70 plus. This is remarkable as one single drug. And remember, we are historically comparing it to multi-drug regimens. I think also what's nice is we know that we can feasibly combine both of these CD123 drugs, the PVEK and TAG, Ryan, with CNS prophylaxis. So it may not be emphasized as much in these programs and in the papers, but we are able to do that. So that's nice to know, because these targeted agents, the BCL2, CD123, they're not thought to cross the blood-brain barrier. So remember, before we used to give multi-agent drugs that might have crossed, remember to make sure to include the LPs. And then possibly these patients, a lot of them are in a better shape, Ryan, going into the transplant than possibly before. Less neutropenic fevers, less hospitalizations, as you were mentioning, more convenience to the patient. You still got to monitor closely. You're watching for the peripheral edema and LFTs, for example, with PVEK. But I do think that it provides a very safe and unprecedented, convenient option for patients. And there is some durability to it as well, particularly in patients who can't go to stem cell transplant, right?
Well, you've really highlighted so many different key characteristics throughout the discussion today, right? The treatment journey for the patient, which is so important, that shared decision making that I think you really complement in your practice, as well as working with multidisciplinary individuals. Love the shout out to PharmDs, by the way, but that's a personal appreciation. And you've also highlighted that BPDCN still remains an aggressive and incredibly rare disease. But our conversation, I think, highlights why continued innovation matters, and not just matters for scientific reasons, but to the patients and the fact that we're providing them better outcomes. So my key takeaways: new treatment options, they're not just simply additions to formulary. They change how we think about response, safety, as you mentioned, site of care, and ultimately getting these therapies to the right patients so we can bridge them or potentially get them to curative therapy. So I want to thank you for this great discussion. I want to thank our listeners for listening to this episode of Unscripted, the AMCP podcast. This episode was sponsored by AbbVie. For more information about AbbVie, go to abbvie.com.